Good evening, everybody. So this is going to be on adjuvant radiotherapy in breast cancer and more focus on what's called fast forward. So before we go on to the fast forward, how did we start our journey in managing the breast cancer basically with adjuvant radiotherapy? So we all know that micrometastasis leads to eventual recurrences in breast cancer. So to counter this or to control or to eradicate the micrometastasis, we have wonderful approaches like systemic chemotherapy and radiotherapy. Okay. So before we plan an adjuvant radiotherapy for a patient who underwent surgery for CA breast, we take into consideration what's the age of the patient, certainly the performance status, tumor size, tumor histology, lymphatic invasion, proliferative rate, hormone receptor status, HER2 status. We don't go more into the gene expression signature because we have very limited data like Oncotype DX, how it really judges people who requires chemotherapy in a selective group of patients. Like we do also have with limited data on Oncotype DX guiding us whether this particular individual requires radiation or not, and definitely the preference by the patient. So coming to the early stage breast cancer, we know that in early stage breast cancer, breast conservative surgery is the main part of main approach that many of the surgeons they do, and then followed by you have radiation, because most of the pain, like all the patients who undergo breast conservation surgery requires radiation. So coming to the radiation, basically when you want to plan the radiation, you need to position the patient properly. Immobilization, you have to use proper immobilization so that the patient can be set up very easily and comfortably every day. And then you need to do simulation followed with target volume delineation, and then plan the process. And then you have to plan what's the kind of a dose schedule and the fractionation schedule that you're going to follow, and then set up verification. And you'll also have to discuss with the patient about the sequel of radiation. So coming to the simulation, this is a very important step. We know that the most important area is the scar and the drain. So these two have to be marked. And what I generally do for all my patients is like the scar drain, I mark it. And then I also mark the entire breast contour so that unnecessarily I do not irradiate the chest wall. And that gives me more confidence when I'm doing the, contouring. And you can use some of the kind of system like motion management you can use that I'm going to discuss later on. So coming to the treatment planning system, like we have conventional planning, we have three-dimensional planning, we have intensity modulated radiation therapy. Fortunately, many of my colleagues are blessed with either 3D CRT or IMRT techniques. Not many people are doing conventional planning these days. Previously, when cobalt-60 was used, conventional planning was done. But today, with existing so many linear accelerators around, we are now using either 3D CRT or IMRT technique. So coming to the conformal radiotherapy, as I mentioned already, it's a setup, immobilization, and then you acquire an image and you need to delineate the target. Your target is going to be whole breast in the early days of breast cancer. If you want to, like, if there is involvement of the lymph node, then you may have to include the axilla. If you are including the axilla, supraclavicular fossa has to be included. But coming to the internal memory chain, but not all the patients require IMN irradiation. Only selective group of patients where you have a high volume disease when you're tackling with, or if there is a tumor which is lying in the inner quadrant of the breast. And coming to the organ at risk, lungs are the most important thing. And second most is heart. Definitely we don't delineate the left anterior descending artery regularly, but some of the centers, they do practice. Brachial plexus is not a problem at all for us because the tolerance for brachial plexus is pretty high. So this is how it looks like in an IMRT technique. entire breast gets uniform homogeneous distribution. With wedges, if you're using the conventional technique, there may be an area of cold and a hot spot. So forward IMRT is nothing but field technique, which is being very much advocated by many people. This is how you can control your dose on the lungs and the heart. That is the inverse planning. It's called a. So undoubtedly, the radiation has really improved the patients with the post breast conservative surgery. And if you take any groups, like the absolute reduction in 10-year risk of any first recurrence is absolutely better with patients who have received RT. These are the lines you can survival curves. You can see those who have undergone only BCS not doing well. Whereas the question here is boost field. Boost means you need to include the scar and the drain area properly into your boost field, and then you have to boost it with a higher dose, because we presume that the area which has been operated, that is the proper tumor bed, requires more radiation because that has got a high potential for recurrence. So you can boost it with electrons, which is generally done for many patients. So you have an linear accelerator, you must be having an electron. So electrons can be used. It's very easy and very low dose to the whole chest wall, and you get very good cosmetic result. Only issue is, like, when you're using a little bit of angle when you're delivering the electrons, you have to be a little careful about your skin dose, because some of these patients can get skin reactions very badly. So your area of interest here would be like your lumpectomy cavity with a 2 centimeter margin on that. This is how it looks like. It's pretty easy. You can mark this is the area of interest that we are going to treat. And this can also be treated by a photon boost if you want to. So you can delineate, but this requires some amount of assistance from the surgeon, like placing a clip. You can see these are the clips that have been placed already by the surgeon, and you can also mark it on the scar, and both can be used for guiding your volume for boost. So here they have used mini tangential fields. You can also use what is called a partial arc. So when you're using a partial arc, that arc comes from here to here, and then it will deliver dose to the interest of area. So you can also do an interstitial boost, but this is pretty, technically expertise is required for this, and sometimes the patients may not be willing to go for these kind of procedures, but this is also very equally good and very easily done. So boost versus no boost. So we have certain group of patients who may not require boost. That is, if the patient is more than 60 years or very, very low grade tumor, favorable biological profile, probably you can avoid boost. Why you have to avoid boost in these patients? Because if you avoid boost, like you can reduce the morbidity, like scarring and induration and local lymphedema, all those things can be reduced. There'll be thickening of the chest wall in that area where you deliver more dose to the breast area. So cosmetic purpose, probably you can avoid boost in very selective group of patients. So other area of interest for today is how to reduce the cardiac toxicity. We know that these breast cancer patients require a lot of chemotherapy, ranging from anthracycline to the neratinib. All these drugs, lapatinib or trastuzumab, pertuzumab, all these drugs have got significant effect on the cardiac. So when you add on radiation with such cardiotoxic drugs, definitely the heart is not going to bear all these things. So you have to control your dose. In any case, you cannot control the cardiac toxicity by any of the drugs. But only thing is, you can reduce toxicity by having a better technique by which you can reduce the dose to the heart. So how? This is a good piece of information from NEGM, where they mentioned that if you increase per gray to the heart, the incidence of cardiac related, like coronary events or coronary events or congestive heart failure is 7.4%. You'll be increasing. So that means every gray of radiation on the heart will increase that individual by another 7.4%. So there are various techniques by which you can reduce dose to the heart. Of all, the most most widely practiced, I would say, is deep inspiration breath hold. Today, most of the centers are practicing this. This is the picture what I'm talking about, deep inspiratory breath hold. So when you're doing this DABH, definitely you can go, your isodosis can go away from the heart. This is the free breathing. Certain amount of heart is included here that I'm going to show you again, by which you can avoid the dose to the heart. And you can also use respiratory gating, prone position, which is little cumbersome for the patient, but it's very good. If somebody has got a very large breast, probably prone position is the best way to reduce the heart dose. Or you can use a proton if patient can afford, or a PBA. So this is free breathing. You see, this amount of heart is included in your field of radiation. So definitely that contributes very high dose to the heart. This is breath hold. You can see very little amount of heart is included in your field of radiation. So you can see that this is the radiation field. I'll show you, this is the radiation field. And this is the heart, which is included in free breathing. And this is the heart, which is away from the PTV in breath hold. So breath hold, it freezes the organ and it separates the heart from the target volume, and it increases the total lung volume as well as reduces the dose to the heart. So what we practice in our hospital is SGRT, that is surface guided radiotherapy. This is how the patient is guided with, whether they're having a very good control on the breathe or not. You can see it on there is a bar here. So I'll show you in this video how, I'll show you why. So this is the area of interest by treating, and these are the thresholds. This will be about 2 mm threshold. In case if the patient is breathing normally high, this is the bar which guides you whether the patient is breathing rhythmically or not. And if anything goes beyond this threshold, definitely this is going to be off. So it is 100% safety as far as patient is concerned, and patient doesn't require to keep any kind of a tube or anything like that in the mouth. So it's very easy and very happily or compliance wise, it's very 100% good for the patient. And as far as safety is concerned, it is 100% safety. So this is from the LNRT. We have got what is the system called 3D surface guided radiotherapy, first of its kind in this entire Asia, and we are proud to say that our center is a center of excellence for surface guided radiotherapy in India. Okay, so and then coming to the other area is accelerated partial breast irradiation. So why you need to do accelerated partial breast irradiation is the thought process for this is we need to irradiate only the area that is close to the tumor bed, that is about 2 centimeters tumor bed, which is got a high prevalence for recurrence. The rest of the breast tissue need not be treated at all. That is the concept. So how do you do this? So you can do either with interstitial brachytherapy or intracapillary brachytherapy like mammocyte or routine 3D CRT or IMRT plan. So initially the indications for partial breast irradiation from ASCO are very much limited, like confined to patients with 60 years old, negative margin, T1 lesions. Later on, the indications got expanded a little bit, but still you have to be very careful. It should be either grade 1 or grade 2 tumor. It should not be more than 1.5 to 2 centimeters, though they mentioned 2.5, but I would say it's 1.5 is almost like a cutoff for all of us. So, and then with the negative margins. So all these things you have to keep it in your mind before you plan for a partial breast irradiation. Partial breast irradiation completes the treatment in just 5 fractions. We deliver about, these are various other techniques by which you can do a partial breast irradiation. This is intraoperative electron therapy, where the entire cavity is irradiated at the time of surgery itself, or you can do using 3D CRT or IMRT plan. So, as I mentioned in my talk initially, that is there anything by which you can avoid radiation, like how Oncotype DX risk score tells you that this patient does not require chemotherapy. Like that, we do have some trials like Lumina from Canada, IDEA from USA, and Precision, but the data is very much limited. But these trials, they looked at post BCS operating like stage 1 disease, N0, high expression of ERPR and all those things. But still, I would say, if I have to omit the patient age has to be beyond 60 or 65 years, then happily, if the patient has got all the features like stage 1, node negative, ERPR positive, then I would probably discuss with the patient and then omit, because there the expected life is about 12 to 14 years. So, but in a case of a 50-year-old female, I cannot do the same thing, because it's little probably a brave decision to take omitting radiation in BCS. Coming to locally advanced breast cancer. So though like patients who have already undergone mastectomy and axillary dissection, is there any benefit? Definitely there is relative benefit in among all the groups like N0 or N1, like nodal status with N1 to N3. But there is also information that patients who have already undergone surgery and received chemotherapy, having like omitting radiation. So here, if you see, patients who have not received radiation are doing worse than the patients who have undergone radiation, those who have received radiation. So that means that systemic therapy is not going to really replace this radiation at all, because systemic therapy is part of treatment, surgery is part of treatment, radiation is also part of treatment. We cannot omit radiation just because you cannot compensate by any other mode. So various dose fractions, because today that we're going to talk about is a fast forward. Before fast forward, we were using what is called 50 gray in 25 fractions, and then 40 gray. And then this fast forward came, which I'm going to tell you now. So coming to the fast forward, way back in 1986, there was a pilot study in UK. Actually, many of these individuals, like many of our friends who are working in UK, especially in Manchester, they keep on doing what is called hypofractionation. Before the concept came, when I was a student in CMC Vellore, I used to see the patients having treated with various different kinds of hypofractionation schedules at Manchester. Manchester is known for hypofractionation. So that's where the origin of these hypofractionation came. So they looked at 15, 25 fractions, 9 in 13 fractions, and 42 in 13 fractions. And then we started looking at what is called START A trial, where they compared 50 gray, 41, 39, and START B is comparison between 40 gray and 15 and 50 gray and 25. So that means by end of 2002, we were pretty confident that this 5 weeks of radiation can be replaced with 3 weeks of radiation. But coming into the practice, I think probably late 2012 or 14, people started practicing this hypofractionation schedules. And then
kindly conclude your talk.
So just requesting, sir, that 3-4 minutes only, if you could just finish it.
I think I'm done with this. This is the last slide, I think.
Sure, sir. Thank you so much.
This is the fast forward. So fast forward, you deliver your entire dose of radiation that is either 26 or 27 gray in 5 fractions. This is what we usually practice. So you just push the entire dose of radiation in just 5 fractions. So this requires a little bit of more adjustment, because you have to clip all these areas and then reduce your volume in such a way that you don't deposit dose onto this lung and heart. So this requires a little bit different contouring process and selecting the fields. So that's how you achieve your constraints. So this is the trial which we were talking about. To our surprise, this is something really good, because what we always think that when you're delivering over 5 fractions, we feel that the acute toxicity is going to be very bad. But on the other side, what we found is this is very well tolerated. Even in cosmetic wise, this is very good. So this is something which gives you an information that whether the patient receives 15 fractions in 40 gray or 26, all these things are almost similar as far as cumulative risk of any breast cancer related events are concerned. So 26 day and 5 fractions has become a standard of care, especially during this COVID era, which has really taught us new lessons like hypofractionation. This is called ultra hypofractionation for prostate and breast, which are very common. So RT improves local control as well as overall survival. It's mandatory for post-BCS patients. Hypofractionation in breast cancer possible and can be practiced easily. Boost, maybe you can think it of. HIMAT is definitely preferred over 3D CRT and conventional techniques. Thank you very much. I'm sorry for, I think I have taken 5 more minutes.
Sorry to bother interrupt you for that, sir. Actually,
It's okay.
Yeah. So thank you very much, sir. Again, a very fascinating thing was, at least for some time ago, we used to think the radiation in breast is kind of done and dusted. The only thing is, like Dr. Ravi Shankar was saying, trying to look for subsets where you could probably give less or more or avoid radiation. That was all we were thinking. And suddenly fast forward came and really kind of opened our eyes towards smaller radiation. Of course, the hypofractionation was already been there for the last 4 or 5 years. And now this trial is really establishing where you can reduce your radiation. So all in all, a very interesting trial, and I'm really happy to note people are following it up and using it as per the guidelines. So thank you, Dr. Shankar. That was a very excellent talk.
Thank you.
So next we have Dr.